The Whipple procedure is already one of the most complex operations in abdominal cancer surgery. But today, many centers perform it using minimally invasive techniques, either laparoscopic or robotic. For patients, this often sounds impossible. How can such a massive operation be done through small incisions? In this video, I'm going to walk you step by step through how minimally invasive Whipple surgery actually works, what happens inside the operating room, and why this approach can be just as safe and effective as traditional open surgery when done by experienced HPB surgeons. Hello, I'm Dr. Kaival, a GI and HPB surgical oncologist. My practice focuses on cancers of the pancreas, liver, and bile ducts. The Whipple procedure, or pancreaticoduodenectomy, is one of the operations I perform most commonly. And over the last decade, minimally invasive techniques have completely changed how we approach it. My goal in this video is to explain the minimally invasive Whipple in clear and simple terms so that you know exactly what's happening at every step. In a minimally invasive Whipple, instead of one large incision across the abdomen, we operate through several small keyhole openings. A high-definition camera gives us a magnified view inside the abdomen. In robotic surgery, the instruments even have wrist-like movements that allow precise dissection in deep spaces. The goal isn't to make the operation shorter or easier. The goal is to reduce pain, blood loss, wound complications, and recovery time, while also maintaining exact same oncological principles as open surgery. The operation always begins with a detailed inspection of the abdomen. We make sure that the cancer has not silently spread to the liver, peritoneum, or other structures. In many cases, minimally invasive cameras actually help us detect subtle disease more clearly because of the magnified view. If everything looks operable, we begin the formal dissection. The pancreas sits deep in the abdomen, connected closely to the bile duct, the duodenum, major blood vessels, and lymph nodes. With laparoscopic or robotic instruments, we carefully separate the pancreas head from the surrounding tissues. We control the blood vessels, divide the duodenum, detach the bile duct, and also mobilize gallbladder, all through keyhole access. This is delicate work, especially around the portal vein and the superior mesenteric vein, where the anatomy is tight. Once the key structures are divided, the entire block, that is the pancreatic head, duodenum, part of the bile duct, gallbladder, and sometimes part of the stomach, is removed as one piece. This block is then taken out through a small incision. Up to this point, the operation follows the same oncologic principles as the open Whipple, only done through finer, controlled movements. After removing the diseased organs, we rebuild the digestive system. This phase is where minimally invasive, especially robotic surgery, truly shows its precision. First, we connect the remaining pancreas to the small intestine so that digestive enzymes can flow again. This joint is called a pancreaticojejunostomy. It's one of the most delicate tasks in HPB surgery. Next, we attach the bile duct to the intestine, restoring the bile drainage. And finally, we join the stomach or the remaining duodenum to the intestine, completing the food pathway. These three reconnections must be tension-free and perfectly aligned to prevent leaks. When performed on suitable patients by trained HPB surgeons, minimally invasive Whipple surgery can reduce postoperative pain, shorten hospital stay, improve the mobility, and cause fewer wound-related issues. But it is not for every patient or every tumor. Cancers involving major blood vessels or patients with extensive prior surgeries may still do better with an open Whipple. The key is tailoring the approach to the individual. Recovery after a minimally invasive Whipple still requires patience. The internal healing is the same whether the surgery is open or robotic. Patients may need temporary enzyme supplements, softer foods, and gradual activity. But many patients notice faster return of appetite, mobility, and energy compared to the open surgery. The long-term outcomes, including margins, lymph node clearance, and survival, depend on the biology of the cancer and the quality of the operation, not the size of the incision. To summarize, A minimally invasive Whipple, the same organs are removed, the same reconstructions are done, and the same oncological goals are maintained. The difference is how we access the abdomen. With the right technology and expertise, we can offer many patients a smoother recovery without compromising safety or cancer outcomes. However, this approach is suitable only in carefully selected patients and may not be appropriate for every individual case. If you found this explanation helpful, please share it with others who might be preparing for pancreatic surgery. And don't forget to like, subscribe, and follow the channel for more clear, patient-focused videos on pancreatic, liver, and biliary duct cancer.